Hello, and welcome to today's Lunch and Learn Bone Up on Osteoporosis. I'm Dr. Todd Beardman, Chief Medical Information Officer of North Kansas City Hospital and Meritus Health. Thank you for joining us. When osteoporosis weakens bones, it can cause hip, spine, and wrist fractures. Our expert speaker today, Dr. James Kesl, will discuss the causes, risks, prevention, diagnosis, and treatment so you can live a more active life. Dr. Kesl is an orthopedic surgeon with Orthopedic Surgeons Incorporated. He earned his medical degree with Kansas City University, and he completed his orthopedic surgery residency with OSI at St. Mary's Medical Center in Blue Springs. Board certified in orthopedic surgery, Dr. Kesl is one of only a few fellowship-trained orthopedic trauma surgeons in the Kansas City area. He also received the 2022 Young Alumni Achievement Award from his alma mater, Kansas City University. If you have any questions about our topics today, submit your question using the Q&A feature below. We will respond at the end of the presentation. And now please join me in welcoming Dr. Kesl.
Yeah, hi guys. Thank you for joining. Important topic for physicians that are involved in orthopedics in general, but especially orthopedic trauma. I may repeat certain things throughout this presentation as to why it's so important to us. A lot of times we think of osteoporosis as just something as simple as, oh, I may have a break when I didn't, shouldn't have gotten one, and maybe it's a surgery, maybe it isn't. But there's actually some pretty dire consequences to having some of these fractures. And the best medicine is just preventing them. I tell a lot of my patients I'd be happy to go out of business at any time, just because these fractures are so bad for patients. We really want to try to catch things on the front end. And so hopefully we can achieve some of that by providing some education and even and decreasing these issues that pop up. So just in general, what is osteoporosis and how are we defining it? In the simplest terms, we would consider it to be, a bone disorder that's just compromising the bone strength. Your bone is continually maturing. When we're born, our growth plates are open. And you're growing as they mature and your growth plates close. Your bone continues to be mature and it strengthens in about the mid-20s to and heading into the late 20s to about as strong as it'll ever be. And our bone turns over time, constantly breaking some of the bone down and rebuilding some of the bone over our lifetime. But at some point in time, whether it be age-related or medically related, we start losing that battle of building bone, and the bone turnover becomes higher than what we build the bone, and that's when our bone just becomes weaker, and it can become so fragile that it can break from a simple fall. It can become even so fragile that you can break vertebral bones in your spine just from even a hard cough. So it can get quite bad. So the question is, are there different severities? And there are, and you may see this if you've ever been involved in testing, because it's not, there's a range. There's normal. And then if you're not quite osteoporotic, you could fit into that range of what we call osteopenia. And it's literally just as you think of it, it's not as bad as osteoporosis, but it's still weaker than normal. And then osteoporosis is when the bone is significantly weaker than normal, and then we really are at increased risk for certain fractures. So there's lots of different risk factors, but if we had to pin some major ones, in general, our female population is the most vulnerable, especially as we become postmenopausal. Now that could be surgical, and in a young patient where you no longer have some of the organs that lead to the estrogen production, or it can just be through the natural aging process. But at some point in time, as you lose that balance of estrogen and testosterone, and the testosterone starts becoming a little more winning in the body because the estrogen isn't as prevalent, the bones start suffering because of that. So that's our most vulnerable population, is anybody postmenopausal. Age factors in, because just as we age, again, the further we get away from our 20s, that bone is turning over and being broken down more than it's being built up. As we mentioned, surgically can be as well for postmenopausal. Different medications can cause this. Certain medications you may be taking can lead to wasting what we call the calcium, as your kidneys won't resorb the calcium or won't resorb certain nutrients, and you're urinating them out due to that medication. The medication could also be causing you to not absorb nutrients when you're eating it through your gut and coming into the body. we encourage you to have a close relationship with your primary care physicians to really make sure you're monitoring these appropriately and making sure that we're following up on these things. Lifestyle in general, if you're a more sedentary individual, you're not stressing your bones, therefore they have no reason to be strong. So having a more active lifestyle can definitely help prevent this as well. Genetics we can't outrun, unfortunately. So sometimes no matter what you do, your genetics may play a factor. And what that comes down to is there, if you have a family history of, hip fractures or osteoporosis, then definitely you want to maybe start thinking a little bit younger in life about how to go about preventing it. And there's disease processes that can cause this as well. So certain things involved with lifestyle, smoking, as we all know, is just bad in general. It can cause many issues, but can definitely lead to weakening bones as the smoking as the chemicals are in your body, it can start basically pulling nutrients from your body. And in general, the bone is a very good source of nutrients, and it will just pull from that, weakening your bones. As we mentioned, sedentary, being active is good. Low body weight factors in. Now, being overweight to a point where it's not healthy is not good either. But being very thin and malnourished, again, if you're very thin and underweight, it probably could be a protein deficiency because you're not eating appropriately, and that can affect the bones. And the other concept is if you're very thin, as you walk, even if you are active, you're not stressing your body because the bone only has to be strong enough to support the very thin nature of your body. So having a toned body that's healthy, well-fed, well-nourished, and just enough weight to keep the bone strong is actually beneficial. But we don't want to swing that pendulum so far that we're dealing with issues that obesity may cause. Low protein intake follows right into that. So again, just being malnourished. Alcohol abuse factors into that as well. And again, typically that's just related to the issues that heavy alcohol use can cause on just your body overall, where your body starts stealing nutrients from places it can get it, and the bone being one of them. Another thing to keep in mind is breastfeeding. You can have people that have transient osteoporosis even at a very young age, because again, as we're breastfeeding, that takes a lot of nutrients to do breastfeeding. And if you're not well nourished in that situation, then your body will again steal the nutrients from the bone in order to produce that milk. And so we want to make sure we're keeping up on our vitamin D and eating well while you may be breastfeeding. Certain medications can cause it. Now, you may not recognize some of these, but if this is a medication that you may be taking or someone knows, make sure that, again, this topic is about education and getting the word out that you could be having side effects from these medications. Dilantin is the brand name, Venetoin, but that's a medication some people are on for seizure type medication, and it can lead to issues with vitamin D and malabsorption and osteoporosis. Anybody's that's on chemotherapy, again, that can be a great medication, as it's getting rid of a product that's not supposed to be there, whether it be cancer or other issues, but again can cause osteoporosis. Lasix or furosemide is a very common medication given to some people that maybe have too much fluid in their body or also just need it to regulate their blood pressure. But one of the side effects of that medication is the electrolytes in your body are again being spilled out through that urine. And if that's happening, your body may need to regulate your electrolytes. And one of the ways it does it is steal some calcium from your bones. So it can lead to issues in that matter. Methotrexate is a medication a lot of times used in patients that have rheumatoid arthritis or maybe some other autoimmune diseases. And it can cause that issues as well. And thyroid disease is pretty prevalent. And so again, if you are somebody who has thyroid issues and is on medication or should be on medication, that may be something you want to consider checking with your regular doctor to make sure that your bones are healthy while being on that medication. And then chronic steroids can do quite a bit as well. Omeprazole, not one we always think about, but that is a medication for gastric reflux. It's very commonly used, and it can again lead to imbalances that lead to weakening of bones. So there are more that are out there, but this is a pretty heavy hitter list that seems to be what I see in a lot of our patients. And it's just good to know that if you're on any of these medications or know someone that is, make sure you're keeping your bone health in mind while on it. When it comes to genetics, at the end of the day, it's the jury's out if pure osteoporosis is actually genetically an issue, but we do tend to see it grouped into families. So I think it's a thing to keep in mind. Do you seem to have a pattern in your family of issues with osteoporosis? And if so, you can get that addressed. you can really deep dive into it and see if there's, issues with the receptors in your body on the cells where vitamin D comes in, as well as estrogen. But for the most part, I wanted to bring it up more so just there seems to be a trend. If dad, grandma, mom had it, maybe that's something you want to start thinking about as you start to age. What diseases do we worry about? This is kind of a little bit of a large list here, so I'll just hit some of the higher ones that seem to be very common in our populations. But again, thyroid disease of any kind, if you have that, make sure you're getting that checked out with your primary care physician, internal medicine physician, or even endocrinologist, and make sure that you're thinking about your bones. Diabetes is also involved in this as well. Cancer, as we mentioned, COPD, and renal failure. COPD, for those that may not know that term, that's chronic obstructive pulmonary disease. Seems to be quite prevalent. It could be whether just through genetic or disease processes or from smoking. But one of the reasons why that can be an issue too is one of the common treatments for that is steroid use to decrease inflammation and allow for better breathing. But chronic steroid use, as mentioned earlier, can lead to weakened bones. So in general, just as some brief education, why won't our bones stay the same? As I mentioned before, as we age and into our 20s, our bone starts becoming mature and about as strong as it ever is, but it turns over. You will actually cycle your bone completely, fully turn it over, break it down, and rebuild it many times over your lifetime. But again, as we get out of balance, for whatever reason, as mentioned before, that is going to be what ultimately ends up happening. There's a fun little slide, as you can see there. That's the boring science part, but I promise that's what ends up happening. And we want to just make sure we're aware of it so that we can avoid having the issues. So now that we have just a little bit of background, how do we find out about if we have osteoporosis or not, or how healthy is our bone? One of the most appropriate things to do is get a test. It's called a DEXA scan. That is as simple as obtaining an X-ray. It's not painful. The radiation dose is incredibly low. It's a very safe test to get, and what it ultimately does is give us information as to how strong is your bone compared to that normal bone of someone that's 25, essentially, and we look to see how far away from normal are you with that. So if you said, why should I get it? I think anybody, if you have concern, try to get the test. It's readily available. But for sure, who should be getting it? All women 65 years or older, all men 70 years of older, anyone 50 years or older, if he has any risk factors that I've already mentioned. And if you've previously had what we call a fragility fracture, if anyone's ever told you you broke a bone, but they don't think you should have, and they're not sure why you broke it, you should be considering getting this DEXA scan. So what do we look at with some of these results? Again, why do we like this test? It's the most accurate way to diagnose for osteoporosis with the least amount of radiation. Compares your bone to that of a normal, healthy 30-year-old. We call it a T-score. And then what does that mean? Nothing other than just we're looking to see how far away from the standard you are. And that number will come back in a negative number. As mentioned before, osteopenia is still weak bone with a risk of having fracture, but it's not as bad as osteoporosis. And that's anyone that has a number of -1 to -2.5. Osteoporosis is anyone that's -2.5 or worse, so -2.6 to -2.7, -3. That is for sure osteoporosis, and you are in that high risk category of having what we call fragility fracture. One point I like to bring up is some of these tests can be a little bit different. If you ask me why, I'm not sure. I wish they were a little more consistent, but I'd like to educate people that it matters. It matters what they're looking at. So if you get this test, one thing we should be paying attention to is what bones were looked at. And sometimes what I see is as the bone, that number can be, say, -1, and you get diagnosed with osteopenia, and we just treat that with over-the-counter medication or vitamin D. But what we really want to look at is where are we most at risk at? So if it looked at, say, the mid shaft of your thigh bone or femur, that's always going to be a pretty healthy aspect of the bone, but some of these tests do it. And so the reason why I bring that up is if that number is high, sitting at 1 or 2, that could bring the average of your score into a more normal range. So what you really want to ask your provider that ordered the test is, what do my hips look like? What do my wrists look like? What is the shoulder? But if you ask me what I care the most about, the most devastating broken bone you can get is a hip. So what we really want to care about is what was that number in my hip range? Because if the number in your hip range, for example, was -2 or -3, but the other numbers brought that down, I would still, as an orthopedic trauma surgeon, consider you to have osteoporosis, and that's very important. So the big takeaway point I would say is you want to know exactly what your number is in the hip aspect of your femur. It's pretty prevalent. If you look at how common it is, a little over 10 million people in the US have known osteoporosis. So the scary part is, what about the ones we don't know? And in general, if you're just looking at low bone mass, 43 million adults have low bone mass. What are fragility fractures? All that means is when you break a bone from something that is considered low energy, or gosh, I don't think I would have broke that bone if I had that fall or that injury when I was 30 years old. If that goes through your head, that's probably a fragility fracture. Now, in my practice, what I see is someone may break their hip and I'll tell them that they have osteoporosis and a fragility fracture, but the patient may say, well, I fell really hard. You know, I landed on that concrete was hard. I always want to shy away from that because, again, put yourself in this position. If I fell when I was in my 20s, would I have had that same broken bone? And if that answer is probably not, you probably have a fragility fracture and should be concerned about osteoporosis. So the classic examples are fall from standing, height, you know, not down a bunch of stairs, just I was at standing, fell over. Doesn't matter how hard the surface is. If you just have that type of fall and break a bone, you probably have a fragility fracture, and we have concern for osteoporosis. What are the most common bones that we look at with that? It would be the vertebral or any of the bones in your spine. It would be your femur and or hip. And I bring that up a lot because we have different terms for the hip, and the hip bone we are talking about is almost always the femur. So for example, it would be the femoral head, femoral neck, or what we call the inner trochanteric region. Those are just the medical terms, but they always say femur fracture. And I know that can get a little confusing because we think in the public of femur as being our thigh bone. And it is, but the femur is still the bone coming up into the hip. So the femur and hip from standing height is the one we care a lot about because it has some really bad consequences. Wrist fractures, or the medical term would be the distal radius, and then any fracture of the shoulder from a fall. Those are the common fractures that if you have those broken bones from just falling over from standing, we really start to worry about the quality of your bone and if you have osteoporosis or not. So getting the DEXA scan, if the question is, should I get labs with that? That's a resounding yes. One of the, we know that we have osteoporosis, but how do we go about managing it? And just like we had mentioned earlier, when there are different disease processes or malnourishments that can lead to it, how we can get a clue for some of this is, what do my labs look like? So for sure, we should get labs with those tests. And the most common things that we should be checking would be our vitamin D level, thyroid studies, parathyroid studies, and general labs don't hurt as well. We should be getting complete metabolic panels and also just checking the blood overall. It's not going to hurt to get these tests, and will give us more information to help diagnose your problem a little easier. I apologize if you can hear that. It's my phone going off. I'm a trauma surgeon, so someone's always looking for me. I apologize. So who should get treatment? If you're looking at true pharmacologic treatment through a prescription, for the most part, if your risk factor is fairly high or you have a T-score worse than -2.5 and diagnosed with osteoporosis, the data seems to be out there that we should be considering some treatment because of the devastating consequences of sustaining a hip fracture that would require surgery and can really lead to functional decline. And if you're not quite osteoporotic, but you have osteopenia, they will still give you a fracture risk within that score. And that's another important thing to make sure you're aware of. And even though you're osteopenic, if your fracture risk or probability of having a fracture within 10 years is 3%, you should really be considering having medication prescribed to you. What do some of these medications look like? The most common medication that we have is bisphosphonates, and that's just a generalized term. You may recognize some of these, you may not. The brand name for some of these that seem to be the most common is Fosamax, Boniva. They all sort of fit into that generalized class of bisphosphonates. And ultimately, I would encourage you to get with your provider, whether it be your primary care, sometimes even OBGYNs will manage this. Orthopedic offices are now starting to have bone health clinics where we will help drive that bus. However it is, just make sure you find a provider that can adequately manage this and make sure you know they have experience with it, and they will get you on the right road to treatment. Just some generalized data over here. If you refer to the slide, alendronate, one example of these, it can decrease your rate of fracture by up to 50%. Resindronate decreases by 40%, and IV alendronate decreases by 40%. So they can all be a little bit different. Again, you want to meet with your provider and tailor make it to you, because these medications can, like other medications, they can affect the way other medications work. If you have any kidney disease, you want to make sure the dosing is appropriate. So just please see your provider and make sure you're just on the one that is best for you. Now, a lot of times I hear from my patients, well, I don't want to take that medication. There's a lot of these really bad side effects. So what do we think about that? There are some side effects from these medications that we do take seriously, and you should be aware of. One of them is what we call osteonecrosis of the jaw. And the way to think of that is it will eat away some of the bone a little bit. I know you find that can be counterintuitive, because you're thinking, gosh, if it's supposed to build bone, why is it eating away bone? Well, just the unfortunate way some of these medications work, they will build bone in other locations, but another location may suffer because of it. One of those could be in the jaw. We routinely worry about that a little more with the IV medication, not so much the oral route. So that's one thing to keep in mind. Fractures of the femur. One thing to keep in mind is that is associated with long-term use. So these are medications that you want to make sure you are taking a break from. We don't want to be on them really long-term. We want to be coming off of these medications. And the way I always describe it is, if I had a ceramic bowl over here on the counter and I had a metal bowl over here on the counter, and I shoved them off, I would ask somebody which one would break. Most of the time, it's going to be that ceramic bowl that shatters, right? The metal bowl is just going to be loud and clunky and make noise. But if before I push it off, I said, which one of these is harder? The ceramic bowl is really hard. So the same concept goes with bone. You don't want your bone too hard, because if your bone is too hard, it's going to act like that ceramic bowl. And when it hits something, it's going to shatter. And I always say, if you could imagine that metal bowl as it fell off, if you had a slow motion camera as it hit the floor, you would see that metal bowl vibrate almost, right? And you can see waves in the metal. It flexes. It's got just enough give so that when it hits something or needs to flex, it doesn't fully break. It's still hard, but not too hard. And that's what bone needs to be. Bone needs to have a little bit of give so that when you have an injury, fall or load it doesn't just shatter. You don't want it to be like the ceramic bowl. That ceramic bowl is super hard, but if it hits with enough force, it just shatters. And that can happen if you're on long-term medication for this. So the one thing to keep in mind is, if you are on treatment for this, you want to have some holidays from the drug, is what we call it, where, and again, this is tailor-made with your provider. It depends on your DEXA scores that you should be getting and testing even while on that medication, but you want to be on it for a matter of time, but then come off it for a matter of time to build the bone up and then let the bone kind of weaken just enough. Not so weak that it's back down to being bad again, but you just don't want it continually climbing to the point where it's like the ceramic bowl when you fall off and it shatters. So something to keep in mind. And then, are there contraindications with these medications? Are there contraindications to not having a drug holiday? Yes. And so if you are someone who is getting worse on the medication, so even if you're on the medication, but your DEXA scan a year or 2 years later is getting worse bone, you are someone who does not need a holiday. You should stay on it because you have proof that your bone is not getting like ceramic. Or if you're someone on long-term steroid use, because we just know that people that have to take long-term steroids, that's a really big issue for bone quality. So if you're in those two populations, you probably don't need a drug holiday, but everyone else, make sure you're not on it for just years at a time. Some of these other options, again, this gets really into the weeds of this discussion, but I just wanted to make people aware of it. There are other options that aren't the bisphosphonate medications. You can do hormone-related therapy, such as estrogen or progestin. Some indications to do this would be, if you're going to go that route, it needs to be within 6 years of menopause. One thing to keep in mind is, for certain populations, that can increase the risk of certain cancers. So again, make sure you're being very diligent with your provider to make sure you're a good candidate for this. Anytime we're taking hormones for medications, we can be at risk for getting blood clots. So if you are somebody at risk for that, you may need to take aspirin or other type of medications with it to lower that risk. If you're also with somebody that has any CVD, the term of that is, any cardiovascular disease, you may not be a good candidate, only because that can increase your risk of having thrombotic events and lead to heart attack or stroke. One of the medications that is very good, in my opinion, it's not for everybody, but it's a very good medication, is this Forteo or teriparatide. But a lot of times you have to work very diligent with your provider to get approval. It is quite expensive, and we do struggle sometimes in getting approval. But it's a very nice one to consider, especially in patients where the bisphosphonates just aren't working. I think it's a very good alternative. And then some of these others that you see down here, they're a little bit less frequently prescribed, but there are just some options that are different. So what else could we consider in regards to help out with our treatment? These are things that aren't prescription and we can easily do through over-the-counter means. So vitamin D3, I bring that up because that's the active form of vitamin D, and that's what we should be supplementing with. And a generalized baseline, it'd be hard pressed to go too high a level of vitamin D if you stuck at this, would be 1,000, what we call international units or IUs daily. And then you can balance that with calcium. Calcium should be about 1,200 to 1,500 milligrams a day. One thing to keep in mind is that's not a pill form all the time. One thing, you just want to make sure you're getting a well-balanced diet. So what I recommend for my patients personally is anywhere from 1,000 to 2,000 international units of vitamin D daily. Now, keep in mind, you may know people that are taking up to even 5,000 a day, and that's reasonable as long as that's being managed and worked with a provider. If you're somebody who's not checking labs at all and you're just supplementing this and never planning to get checked, I would stick around that 1,000 to 2,000 international units range. And then with calcium, I would just personally take a multivitamin that has calcium in it, and then make sure you're getting a well-balanced diet, not add calcium, because if your diet is well-balanced, you will get a lot of your calcium from that diet. And the reason why vitamin D is important is you could take all the calcium in the world, but if you don't have enough vitamin D, you won't actually absorb it through your gut. You need the vitamin D to help you absorb the nutrients that you are getting through your diet. Balanced diet in general is helpful for the calcium, and in general helpful to maintain your body mass, as we discussed earlier. And ultimately, be active. The more active we are, the better health we're going to be in, and that includes the bones as well. They're an organ, and we want to treat them just as we would treat any other organ and be healthy. I bring up the scary stuff because why is this important topic to us as orthopedic trauma surgeons? And not to scare anybody out there, but maybe just a little to make you go and consider getting treatment and make sure we're being as preventative possible. But probably the worst injury I personally see, because it's so frequent, is hip fractures. And I really don't like them because in a way they can be preventative. But hip fractures in the United States, we have pretty good data. And what we know is, I have some numbers in here, but it's essentially what I tell patients, it's the rule of thirds. For sure, it's at least a 20% increase in, not mortality, apologize for that, it's mortality. But ultimately, when you break your hip, we know that for the most part, anybody that's for sure 75 years or older, when they have a hip fracture, from the minute that happens, there is a risk of 1 in 3, so 33% essentially risk of passing away within 1 year of having that hip fracture. So that's pretty scary. And then that goes back to patients that say, hey, I don't want to take that bisphosphonate medication, or I heard there's risk. A lot of times what I respond to that is, well, I know the risk of a hip fracture, and that risk is 33% of dying from a hip fracture within a year, and those medications don't have that risk factor. So it's pretty scary stuff. So let's just say you're not in that 33%, which is the hope. What does it look like? Well, only 1 in 3 return to their baseline function. So from the minute you break your hip, you only have a 33% chance of being as active or as healthy and functional as you were before. So the unfortunate truth is, the minute you break your hip, it's rare for that individual to get back to their previous level of function. So we really, really want to try to prevent these. And then, if you've already had one hip fracture, you're at 10 times risk for having another. So even if you're somebody out here who knows somebody who's had a hip fracture, or you may have had one, it's never too late to go get treatment, because we don't want to break the other hip, because those risks are just as bad the second time around, if not even worse. And if you've had compression fractures or know somebody that's had compression fractures, those also have an increased risk in mortality, as quoted below here. There's a 15% increased risk in a 5-year mortality after having a spine fracture from just a ground level fall. And then not only that, even if it doesn't cause mortality, it can cause residual issues with respiratory, quality of life, and balance, which can lead to further falls. And we've already know that that's bad. And ultimately, if we wanted to know what's our best predictor of having a fragility fracture or a fracture of osteoporosis, it's having a history of prior fragility fracture. So as I'd already mentioned, if you've ever had a fracture before or know somebody that's had a fracture, it's never too late to go get treatment on this, because prevention is the best medicine. I think that sums it up for this aspect of it. Be happy to field some questions at this point.
Well, thank you, Dr. Kesl. Some wonderful information. We do have some time for questions. And maybe the first one is, are there some steps that anyone can take to keep osteoporosis from worsening?
Yeah, exactly. So one of the things to do is look at your lifestyle, right? So if you're somebody who was maybe not active, I think finding a way to be active. We have many, there's many resources, local community centers, WISE, North Kansas City Hospital, for example, has a very nice situation open to the community where you can be involved in the workout center here. North Kansas City Hospital, we're a private practice within this institution, but really like North Kansas City Hospital with the services we can provide. Just getting involved, being active, being proactive, finding out the things you can do, eat better, be a little more active, get a personal trainer. At the end of the day, you can't outrun genetics and you can't outrun bad luck sometimes, but you can for sure outrun bad luck or just ignoring things. And I think becoming an active person and hitching yourself up to a health community such as Meritas, North Kansas City is only going to give you a better chance to prevent these things from happening.
Great. You talked a little bit about the testing with the DEXA scan. How frequently would you expect a standard patient to have that DEXA scan performed?
Yeah, I think once you fit into that category where you need it, as mentioned earlier in the talk, you should be doing it every 2 years. I feel pretty strongly about that. And if there's anything that changes in your health or you see trends in the wrong direction, we could always, insurance approval sometimes becomes an issue, but even out of pocket, I wish I knew the exact number. I don't know, but that's something anybody could get you that information. But we always, as your healthcare providers, are willing to fight to try to get test approved. But at minimum, I'd say every 2 years. And if for some reason you're having a worsening or change, it doesn't hurt to get it at any time, really, because there can be wild fluctuations. I've seen it in my own practice.
Great. We talked a little bit about nutrition, and are there some specific foods that can help increase bone health, and to what degree do those foods help?
Sure. So, at the end of the day, if you really need the help, the structuring your care plan with your provider is going to be the best way. But just a generalized, well-balanced diet. I know that seems a bit vague, but there's not like one specific food that's really going to give you that bone health that you're looking for. What we know is that you don't want to be undernourished. So proteins, well-balanced diet, protein. What I see a lot of my aging population patient is their appetite just may not be as good. They may eat, but it's not quality proteins. So if you fit into that category, adding a protein shake to your daily regimen is important. And that's where I think, again, a health institution like North Kansas City, Meritas can be a good resource, because there's dietitians and things of that nature. That's where I would start personally. If you're somebody who thinks maybe my diet isn't good enough, I would try to hook up with a healthcare partner and see a dietitian. They can walk you through very good resources to get a better balanced diet to help your body function a little better.
Great. I remember during the talk, you talked about exercise. And are there some specific forms of exercise that are better than others to help build that bone mass?
Yeah, good question. So just weight-bearing exercise, so any exercise is good. And if you're someone who, for whatever reason, can only do the pool or can only do non-weight-bearing exercise, we'll take it. Any exercise is better than nothing. But if we are having the ability to do any type of weight-bearing exercise, that's always going to be better. It's going to build that bone mass. That could be just something as simple as going to a walk, to where if you're someone who has the strength to do a jog or something more aggressive, that's okay. Ultimately, we want to be safe. Fall prevention, how do we not break our hip? Don't fall. So you want to exercise safely and efficiently. And but anything that involves putting weight through your legs, through your body to build that strength up is going to be the best thing.
Along those same lines, is there any age limit to where that physical activity and that weight-bearing exercise won't really help me as much?
I don't personally think so. I mean, there may be some data you can find out there where, yeah, there's a taper off, but at the end of the day, I don't think it's ever It's never going to be bad to be active, and I routinely tell my patients that even are recovering from surgery, well, hey, we really want this surgery we don't have to do this again, because unfortunately, anytime you have the surgery, the bone has to heal or the hip replacement has to heal. So, we say we want to take it easy. I always tell my patients, I'd rather you be healthy and active and in shape, because if God forbid we have to have another surgery, you need to be healthy and in shape enough to handle the other surgery. So I think being active, whatever we can be at any age, is going to be beneficial.
Great. I know you mentioned some specific ranges around vitamin D dosing and gave some caution around not overdoing it if you're not being monitored. How much vitamin D is too much? And is there anything that we need to watch for there?
Yeah, for sure. So again, I think if you're really going to be the best benefit of this, you would do this with a provider of some sort and get labs to be checked on for this, because you can get your vitamin D level checked, and that's the best barometer for it to see, am I shooting too high, am I not? As I mentioned in the talk, if you're somebody who's not getting it checked, I'd err towards those lower levels, I said, because at least it's something, and it's rare to go above. But one of the things you'd be worried about if it goes too high, right, would be probably some symptoms associated with too much calcium, right? So if you're getting what we call, hypercalcemia, you can have abdominal pain, frequent urination, nausea, vomiting. And so ultimately what I would say is, if you're taking a lot of vitamin D and you start feeling different, probably go get checked out, because you could swing the other way. And you want to be careful. On that same caveat, again, we want to be cautious and not swing the other way, but it is hard. A lot of people are low on vitamin D, and I treat vitamin D pretty frequently, and even people where their labs have swung on the end, I'm like, okay, let's back away. They're doing okay. So again, we always want to be safe and monitor that and look for it, but I do think I'd rather you be taking it, and then just look out for certain things than to say, well, I'm not going to take it because I don't want to fall into that category. I think it's good to just take it, but ultimately the best combination would be monitor it with a provider.
Wonderful. Well, we really appreciate you taking the time to visit with us, Dr. Kesl. We hope this presentation was informative and helpful. And if you would join us again on Thursday, February 16th for AFib, Don't Skip a Beat, with Dr. Richard Mills, who is a cardiologist with Meritus Health Cardiology. Again, thank you for joining us, and have a great afternoon.